So I would like to welcome Dr. Mary Rysavy to the podium. She is a resident in obstetrics and gynecology here at UW Hospital. She's taken the QI course before and has collaborated with us, and she has worked in Mozambique. So some of her insights about global stuff draw on that experience. But we've asked her today to talk about the work of her department in relation to family planning. And when we've talked about this QI perspectives, I told you you'd be hearing about experts. You'll see how they're thinking about quality improvement and the state of the art and best practices. When you find out about new best practices, what do? How do you put it into practice? So that's what we'll be hearing about from Mary today. And I'm going to ask her to complement what I've said with anything more of introduction that you would like the group to know about you. So welcome, Dr. Rysavy.
Hi, so yeah, I'm Mary Rysavy, actually, and that's okay. Yeah, so I'm a third-year resident in OBGYN, and my training background is that I spent 2 years in Mozambique before medical school, and throughout medical school I worked with a couple of different projects there, primarily in maternal and child health. And so currently I'm working on a project there related to infant nutrition and helping a community to support babies who develop failure to thrive after birth. But today, Lori had asked me to speak about a new initiative in our OBGYN department based on family planning. And this is an initiative that we're working on making both local and global. We've recently developed a partnership with an OBGYN residency in Hawassa, Ethiopia. I think we have some visitors from there. I haven't had a chance to meet you guys yet. But our hope is that this project can not only meet a very real need here in Madison, but will also be something that we can help to implement globally as well. So with that, I will talk about our project. So our project is we call it the Ryan Lark program. So this program generally aims to provide training for OBGYNs residents in placing LARC, long-acting reversible contraception, and also aims to provide reliable contraception for at-risk women. I'll go into that now. So the first thing that we had to do, as it sounds like you guys are all doing today, is to identify a need. With any quality improvement project, you're looking at some sort of need in your community that needs to be met. And so the need that we identified here was a need for increased access to reliable contraception for low-income women in the postpartum period. And so this was something that we've seen for many years, that women who were coming into our clinics, particularly our resident clinic here in Madison, we see a very at-risk population, women who have Medicaid or don't have insurance or have high-risk social situations. We see a lot of teen pregnancies, young women getting pregnant, and then we unfortunately often also see these women get pregnant over and over very soon after they have a child, and this puts them at even higher risk for difficult social situations. So one problem that we identified is that insurance, and particularly Medicaid in Wisconsin, will not cover a postpartum placement of long-acting reversible contraception. And the reason for this is a very bureaucratic technical one, but in the hospital, if you place an IUD or an implant for contraception, the hospital doesn't get reimbursed any more for that procedure than they would if you didn't place it. So if you place that contraception in your clinic, you get reimbursed for performing a procedure and for the device and whatnot. But if it's placed in the postpartum period in the hospital, the insurance does not pay them anymore. So most insurance companies will not pay for that to happen. So that's a problem in and of itself, but then also with the population that we are looking at, we have the social pressure, the social situation here that these women have difficulty following up. So, a person with a higher income in a private insurance probably comes back to their 6-week postpartum appointment and they can get an IUD or whatever form of birth control they want, and they talk about that with their doctor and it's no problem. But a lot of the women that we are worried about, for whatever reason, are not following up after they have their baby. So the one point at which we can have access to help them with reliable contraception is when they're in the hospital having their baby. So this is the need that we identified. And then just some background about this. So long-acting reversible contraception. Here in the U.S., we have 3 main LARCs. One is called a Nexplanon, and this is a very small plastic implant that has a small dose of progesterone in it, and it's released slowly over time, over 3 years. So this gets placed in the lateral arm, and it stays in place. It can stay in place for 3 years and provide very effective contraception. Intrauterine devices, we have 2 available. Actually, we have 3 available now, but we have a Mirena, which is a plastic IUD that's impregnated with progesterone as well, and that's released slowly over 5 years. And then we have a Paragard IUD, which is a copper IUD, and that has no hormones and provides reliable contraception for at least 10 years. There's a third IUD that's very similar to Mirena that was just released in the market in the past couple months called Liletta. We can talk about that later. But all 3 of these options provide 99% effective contraception in the time periods that they're approved. And so right now that's the most effective form of contraception that we have, actually almost as effective as tubal ligation. And so these methods of contraception have a lot of advantages over other methods that are available. So there's no maintenance involved. Once a clinician places one of these 3 methods, there's no need for the patient to do anything. They don't have to take daily pills like you would with oral contraceptives. They don't have to get a shot every 3 months like you do with Depo-Provera, and they don't have to, use anything when they're having sex. And so this reduces the risk of improper use. A lot of the unplanned pregnancies that we see come from someone forgetting to go back in to get their Depo-Provera shot, or forgetting to take an oral contraceptive pill, or forgetting to use a condom, things like that. And so by having these very effective methods, we're able to sort of take out one major barrier for people in unplanned pregnancies. And then also these 3 methods are safe and effective for women of all ages. And that's something that, at least here in the U.S., has been kind of a major myth for many years, that IUDs particularly were thought to not be safe for women who were younger or had not had children. But studies in the past few years have shown that they're definitely effective even in women who've never had a baby, and even in women who are very young. And so the Nexplanon, the implant in the arm, is actually a really great option for teens and for younger women because they don't have to undergo a pelvic exam to place it, and it can be taken out and replaced with another one immediately after 3 years. But the IUD obviously lasts longer, and it is just as safe for younger women too. So we found our need, and then that is a background on the contraceptive program that we were using. The Ryan program is the program that we partnered with to get funding for this project. Ryan program is a national incentive here in the U.S. to increase access for OBGYN residents to training in family planning. This program provides funding, technical support, and educational materials, and it primarily actually focuses on an opt-out training program for abortion provisions. So our residency program is a Ryan training program, and many programs around the country that have this provide at least 1 month during the 4-year residency that residents can participate in learning to do abortion training. But the Ryan program also wants to provide access to family planning training in other ways. And so our program that we propose to them is one such way that they can do that. So this is post-placental or the IUD and Nexplanon training is not at all related to their abortion provision, but it's just another aspect of their family planning training for residents. So that's a little background on the program and then the implementation of our project. So we set guidelines to identify patients who would qualify for this program. And these included patients who qualify by income. So here in the U.S. we have a chart that is used for a lot of different income qualifying programs in which we qualify the federal poverty line, and that is a number that the government has calculated as an amount of money that a person or a family can make and still reasonably survive comfortably in our country. And so patients who make less than 300% of the federal poverty line are considered low income in our clinics, and so they will qualify for this program. We also consider any patient who has no insurance at the time that their contraception would be placed, and so this includes any patients who have Medicaid at the time of their delivery, because Medicaid will not cover the placement of these devices for patients right after delivery, as I explained. And then we decided that the LARC placement would need to be postpartum, so less than 10 weeks after having a baby, or that the patient is a part of a vulnerable population. So we focus a lot on the postpartum population because this is something very new that wasn't available before and is a way to identify lots of our patients, but we decided to also include patients who are part of a vulnerable population at any time. And so that is including adolescents, so anyone 13 to 19 years old, anyone who is medically complex, meaning that they need to prevent pregnancy due to a significant medical problem that a pregnancy would adversely affect their health, and or someone who is socially complex, so they need to prevent a pregnancy due to very significant or adverse social situation. And then enrollment, we looked at the various ways that we could identify patients for enrollment in this program, and that we decided that the main way we would identify patients was during their prenatal visits. So I'm not sure how the prenatal system is set up in all of your practices or your countries, but for us, we tend to see patients about once a month during their pregnancy, from approximately the time they become pregnant around, or know that they're pregnant around 12 weeks up through 32 weeks, we see them once a month. And so this is something that we've started addressing actually at their first prenatal visit. Just, was this a planned pregnancy? Do they intend to have more children in the future? And if they don't intend to have more children right away, what their plan is for postpartum birth control. And so then we offer this program to patients that we think would be part of those qualifying patients. So ideally, we try to review that checklist and see if our patients would qualify by 32 weeks so that we can have them sign the consent forms and enroll in the program by 36 weeks so that once they deliver, ideally between 37 and 40 weeks, that they're part of this program if they qualify and want to be. And then making sure that we place a copy of the enrollment forms in our charts at both our clinic at UW and at Meriter, which is the hospital where our patients deliver. So this is a copy of, it's kind of small, but this is a copy of the handout that we've been placing around our clinics and that we go over with patients. And we talk to the patients about safe, effective, and forgettable contraception, so a way that they can prevent having a baby until they're actually ready to do that and want to. And then this is a little piece of the resident training handout that we go over with our residents who are being trained to place the devices. So this is just showing the IUD itself in the ring forceps or in your hand and placing it into the uterus immediately following delivery. And so this goes over the technique and the contraindications to doing this, some of the expulsion rates of IUDs and other points. So when we rolled out this program for the first time last fall in November, and we had a morning training session with all of our residents, and which we went over the placement and sort of all the qualifying and contraindicating factors for the program. So that's a brief overview of our program, our current project, and then of course going in the future, the project is really only just beginning, and so where we go from here is kind of monitoring and evaluation, keeping data on who we've placed this in, how the project is going, and then planning for analysis and follow-up of these patients looking forward in order to identify whether we've been actually able to affect unplanned pregnancy rates in this vulnerable population in our community. And then a major part of this project, which has not really gotten fully off the ground yet, but is the hope that we can connect this locally to globally, working with our Ethiopian colleagues. And so a big grant that our department has gotten recently is to work with the Hawassa OBGYN program on developing a LARC program in their community, and also helping them to develop the techniques in laparoscopic surgery that they could use to deal with complications of IUDs and LARC placement. And so that has been a huge part of our global health initiative in our department this year, and we're looking forward to working with them on that.